Good evening, everyone. I welcome you all on behalf of Department of Pathology to CPC of August 2022. I extend a warm welcome to Dr. Navin Khattry, who has joined us virtually from Tata Memorial Center, Mumbai. Hi, sir. I'm Dr. Kavneet. I'll be discussing the pathology part of the CPC. So I now invite Dr. Atul Sharma, Professor in Head, Department of Medical Oncology, to introduce the speaker.
Hi, Navin. Good afternoon. So a warm welcome, at least virtually. We expected you to be around physically. So let me introduce Navin. I know Navin for about 20 years now, and he's passionate about medical oncology. So one instance, he joined radiation oncology as junior resident, and that time we changed our DM entrance rules. So we probably were not allowing any more radiation oncology. So he resigned from the radiation oncology post and joined PGI as a internal medicine candidate. He finished his internal medicine in 2002 and came to us for the DM medical oncology, completed in 2005, and thereafter went to Bristol for training in the bone marrow transplant. After coming from the Bristol, he joined Tata Memorial Center, and he's credited to establish the bone marrow transplant unit at ECTREC. Currently, he's working as Deputy Director at ECTREC and also Professor of Medical Oncology. He has close to 80 peer-reviewed publications to his credit and also authored 7 book chapters. He's very keen in the bone marrow transplant program. And so, Navin, over to you.
Thank you, sir. Thank you for the kind introduction. A very good afternoon to everyone. At the outset, I would like to thank Dr. Sharma and his team for requesting me to do this CPC. Yes.
Is it now visible?
Yes.
Speaker.
Yes. Okay. Okay. So sorry for that technical glitch. So this is a case of a 22-year-old male who presented at ICH with fever in October 2020, and this was associated with night sweats. He was found to have axillary and right cervical lymph nodes, and I think there was some delay in the diagnosis till March 2021, where PET-CT showed an anterior mediastinal mass with abnormal cervical influence and an osteolytic expansile like lesions in the third and fourth ribs and the body of the stem. The histopathological diagnosis was done from the mediastinal biopsy, and the diagnosis has been kept away from me, so that probably I need to discuss what would have been the possible diagnosis. However, there is some lead to what the diagnosis would be because he received frontline chemotherapy 3 cycles. Unfortunately, he had progression with chest swelling, and then salvage therapy was given, 3 cycles of another course of another chemotherapy, and he achieved partial remission. He then underwent autologous stem cell transplant in the first partial remission, and the conditioning used was one of the standard regimens that we use for lymphoma, which is known as B, which includes T for carnostin or BCMA, E for erythrocyte, A for RSC, and N for melanoma. And the dose of stem cells given to him was 4.5 million cells per kilo of CD34. So the basic diagnosis is most likely lymphoma for the simple reason that it is more common to have mediastinal mass with cervical and axillary lymphadenopathy in lymphomas rather than in solid tumor. And the fact that he was treated with chemotherapy followed by autologous transplant, it's mostly in lymphomas that we do transplant if the response is not good. And the beam conditioning is very typical for the conditioning which we use for autologous transplants in lymphomas. Now, the more difficult question to answer would be the type of lymphoma. I'm not sure what was the type of lymphoma, but I can probably predict to some extent that most likely it would be a diffuse large B-cell lymphoma. It could also be Hodgkin lymphoma or some of the uncommon lymphomas like anaplastic cell lymphoma or other T-cell lymphomas. Now, why I say that probably is a diffuse large B-cell lymphoma? For the simple reason that the bone involvement is common mostly with diffuse large B-cell lymphoma. It is not common in the others, so of course it can be in other lymphomas. And the Hodgkin lymphoma typically after 3 cycles of chemotherapy, one usually does not progress. It's more seen in aggressively diffuse large B-cell lymphoma. I did do a differential of other lymphomas like anaplastic cell lymphoma, which can also present with bone lesion, which is local because of the mediastinal mass and body extension there. However, that is probably lower in my differential. So, as far as the diagnosis is concerned, I will keep diffuse large B-cell lymphoma and aggressive B-cell diffuse large B-cell lymphoma as my first diagnosis. Now, from the large data under the International Experimental Lymphoma Study Group, the DLBCL has the most common propensity to involve the bone, and that is what we also see in our clinic. With Hodgkin lymphoma, there is around 8 to 10% that bone may involve, but again, it is something which one can keep in mind, and it is also a possibility that I will keep it less in this definition. So the patients receive the beam condition, and that is usually given for 6 days before the stem cell infusion, and the stem cell infusion was done on the 6th of October 2021. After the stem cell infusion, typically the patient goes through a course of the blood neutropenia and mucositis. So this was nothing exceptional in this patient. From day 4 to day 10 post infusion, the patient went through the typical course of neutropenia with fever and mucositis. The Navin AIIMS, that's the absolute neutrophil count, was 0 between day 2 to day 8, and the margin platelet was 18,000. At some point in time, because of the neutropenic sepsis, a program and galactomannan were done. And as far as I can see, they were not contributory to the whole course. We typically give growth factors support for a few days till the counts up, and that's exactly what was done for this patient. Now, what was unusual is that on day 10, the patient developed some respiratory distress. There was hypoxemia, and the treating unit felt that it could be PCP with engraftment syndrome. And that happens in post-transplant course, especially the engraftment syndrome. And for those who are not from dermatology, medical oncology, the engraftment syndrome is a typical syndrome where the counts are rising after high-dose chemotherapy and transplant. Where when the counts are rising, there is a cytokine storm which leads to sometimes fever, skin rash, substance accumulation, and in rare cases, respiratory distress. And the treatment for engraftment syndrome is steroids, which was given in this patient. The patient improved and he was discharged on day 17 on taking doses of steroid. Now we have a series of scans here. So this is the day 12 post-transplant scan, where you can see that the upper lobes have ground glassing in both the upper lobes, and it's also present in the right lower lobe. What is also seen in the medius of the window is a residual mass of the initial diagnosis of what I perceive as lymphoma. I'm not sure what the CT brain was done. It wasn't very clear from the history which was given to me. However, from this ground glassing, engraftment syndrome is a possibility. Other possibilities I will discuss in the next few slides. So the patient was discharged from steroids, and the patient then was admitted on day 31, that is within 2 weeks of the initial discharge. And this time the patient came with low-grade fever and worsening breathlessness. The saturations in room air was 88%. So on the 6th of November 2021, a CT scan was done, which showed an organizing pneumonia with action bronchiectasis and fibrosis. The complete blood count with the biochemistry was unremarkable. Typically, when we are not sure of the diagnosis, then we go into the rule of infection, and a bronchial advance was done on the 19th of November, where the AIP stain and the GS score was negative. There was some Yersinia pneumonia growth, which apparently was insignificant, and the patient was then restarted on steroid, 13 milligram, and azithromycin was added, and the symptom was continued from the previous study because the treating unit felt that it was PCP on day 10 when initially he had breathlessness. There was clinical improvement. He was off oxygen by the third admission, and then he was discharged. Now, I would like to compare the two scans of day 12, which was just 12 days after transplant, and day 31 days after transplant. So the initial scan, as I said, there was downmass in the upper lobes and the right lower lobe.
And what we see now is interstitial fibrosis with bronchiectasis in both the upper lobe and the right lower lobe, in all those areas where ground glassing was there. Now, this is typical of something which has some inflammation which must have happened, after which there is fibrosis. Now, I would like to discuss more on what the lung injury would have been at day 10, and then which again recurred after the patient was on tapering steroids. Engraftment syndrome certainly is one of the differential, and that typically happens when the counts are rising after transplant. So even I would feel that engraftment syndrome, which is the peri-engraftment respiratory distress syndrome, which is one of the most likely diagnoses. However, one aspect which tells me that probably there's more to the eye than what can be seen is that there was fibrotic sequelae at day 31 in the same areas where there were ground glassing. Now, this typically does not happen in peri-engraftment respiratory distress. So then one has to look what could have been the other causes. PCP, I would keep low in my differential for the simple reason that during the first 2 weeks of transplant, PCP is not the common infections in the respiratory tract. And the reason for that is that they are usually confined to single rooms, HEPA-filtered rooms, where PCP probably would not be an important diagnosis, but yes, it can always be. So I would keep PCP lower down in my differential. What interests me more is the BCNU induced lung injury. Now, BCNU or carmistin is one of the components of the high-dose chemotherapy which we give for transplant in lymphoma. And it is known to cause pneumonitis, just like other chemotherapeutic drugs like bleomycin. However, they respond to steroid. When you taper the steroid, then there is recurrence of the lung manifestations. The only issue with this is that usually it is more insidious, and the median day is not usually the 10th or the 14th day, it's around 21 days. However, what makes me go more in that line is that the fibrotic changes that we saw in day 31 is more with lung injuries due to drugs rather than anything else. Now, what do we know about the lung injury because of BCNU? So this is a large data set from the Dana-Farber Cancer Institute, wherein more than 200 patients who received carmistin-based conditioning regimen for autologous transplant, pneumonitis was seen in 22%, of which 19% received systemic steroids. So obviously, BCNU-induced lung injury is probably more than what we diagnose. Now, the important thing there is that the median onset of symptoms were not within the first 14 days. It is usually after the 3rd or the 4th week. And 20% of patients had recurrence of the symptoms when the steroid was stopped. And in our patient too, when the steroid was tapered and possibly stopped, there was recurrent symptom of breathlessness, which again responded to steroids. Now, peri-engraftment respiratory distress syndrome is also common after autologous transplant. And this data comes from Mayo Clinic. And in their large data set, what they found in more than 3,500 patients, the incidence of peri-engraftment respiratory distress syndrome was around 5%, which again is not uncommon. We see a lot of engraftment syndrome in our patients, but we don't typically see the lung injury with it. And again, this is a definite possibility. Now, in this cohort from the Mayo Clinic, those who underwent CT chest, fibrotic changes were seen in a minority. So it is not that you may not see fibrotic changes with engraftment syndrome, but you will probably see more fibrotic changes with drug-induced lung injury rather than engraftment syndrome-related respiratory complications. So he was then discharged in November, sometime in November, and then a second readmission happened on the 3rd of December, that is day 58 post-transplant. Again, there was the same symptoms, fever, breathlessness, and this time there were crepitations and there was more hypoxia, and so he was on high flow oxygen. A CT scan done on the same day showed bilateral GGOs. The blood count was suggestive of some neutropenia. The procalcitonin was normal. And for some reason, the PET CT was done on the 6th of December. And I would feel that PET CT was done because probably there must be a lurking suspicion that this must be a relapse of the disease, the basic disease, which in most likelihood was a lymphoma. So the PET CT showed metabolically active lymph nodes and a cerebellar lesion. Ferritin and triglycerides were also done, and I believe it must have been done to rule out HLH, because he was coming back with fever again and again, and this time the blood counts were also low. Bone marrow studies were done, and bone marrow studies were contributory. The lymph node biopsy was done, of which I'm not aware what it was, and probably that's where the answer lies. And the patient was started on treatment based on possibly the lymph node biopsy, and the patient responded to treatment. Now, within a month, a repeat PET CT was done, which was suggestive of a good response. However, there was a new consolidation in the right upper lobe lung, and he remained well for 2 months. Now, this is the PET scan in December, the day 61 PET scan, and you can see that there was a cerebellar lesion out here. There's a nodule here. In the lung, you can see that there were few nodules in the lung. One is very prominent. There is ground glassing. And then if you look at the supraclavicular regions, there is uptake in the lymph nodes there, which is pretty significant. And there is some lymph nodes even in the paratracheal region. So this was in December. Now, after a month of response to whatever treatment was given, you can see that the lung nodules have disappeared. I have not put the brain scan in this. The cerebellar lesion was also not there. And there was still some lymph nodes in the supraclavicular which showed uptake. And there is some mediastinal lymphadenopathy which was also there. So there was, I would say, more than a partial response to whatever happened in December and whatever treatment was given in December. So what went wrong in December? That is day 58, when he came back with breathlessness and fever. In my opinion, I think it was an infection, and it probably wasn't the relapse of disease at this point of time. Why do I say that? Firstly, the patient already had been given steroids for a long time. So there is a setting for infections to come up when you are on steroids for a fairly long time. And even in autologous transplant, the immune system does take some time to recover. So there is some immune compromise. Now, what is important is that this patient responded to whatever was given after the lymph node biopsy, I would say very early and dramatically. There was a prompt response to whatever treatment was given. If it was the disease, the malignancy, I don't think it would have responded. It's infections that respond pretty well and quickly. And that we saw in the response PET scan. Now, in the summary which I received, the patient was fit enough and was contemplating to travel to UK within 3 months of what happened in December. Now, I'm sure that the clinicians would not ask him to go to UK within 3 months of a relapse of the malignancy, because it will take more time. So this again tells me that probably it was not the disease relapse, it was probably infection. And this early relapse of disease is very aggressive of lymphomas, if this is lymphoma. And again, I don't think the CNS lesion which was there would have responded. So keeping these in mind, I would think that it was infection rather than the relapse of disease. The next question would be, which infection? Now, there are plethoras of infections which happen post-transplant, but one has to sieve out to see what is common. Two things which are very common in this patient is that there is something in the lung and there's something in the brain. So obviously, one has to look at what infections happen in the lung and the brain. And of course, the lymph node, because a supraclavicular lymph node biopsy was also done. So if you look at this table, these are some of the organisms which which involve both the lung and the brain. What I feel is what I would put in the differential diagnosis would be a more chronic or subacute infections like mycobacterium, nocardia, or maybe fungal infections. Now, I would delve in each one of them to understand what could be the possibility if it was an infection. In my mind, tuberculosis always remains the first because in India it's one of the most common infections. TB presents in any way, and disseminated presentation with lung and brain is very well known in tuberculosis. Prompt response to treatment, as in this patient, happens in tuberculosis. The patient was discharged, so I believe he must be in the OPD, and the OPD treatment is what happens rather than being admitted and given parenteral treatment. Now, what is odd is that they don't usually present with an acute respiratory failure as the way he presented in December. Now, there was a BAL done in November. At that time, the TB was negative, but this symptomatology happened in December, and that one was the previous in November. And what I feel the November was probably the lung injury because of either engraftment syndrome or the BCNU. The December probably was an infection, and at this point of time, the BAL was not done. Now, the next differential in infection would be nocardia for me. Again, it causes disseminated infection. CNS involvement is known. Treatment on OPD is possible because this patient was discharged. However, the CNS involvement usually requires IV antimicrobials, and this patient most likely was discharged. This patient was on Septran for a fairly long time, though the duration is not given. So if you are on Septran prophylaxis, then the chances of nocardia is less. So that is why I would say that probably it's my second differential. Though, of course, breakthrough infections can happen. Now, what is striking is that this patient had lymph node involvement, supraclavicular, and a lymph node biopsy was done. This is usually not seen in nocardia, and that is something which I think probably is against a nocardial infections. Nocardia requires prolonged treatment. The response treatment is also delayed, and these are also some things which will put nocardia in my differential a bit lower down. The non-tuberculous mycobacteria, there are quite a few, and any one of them could be a possibility. However, again, the CNS involvement is not so common. Parenteral IV antibiotics are usually required, and the response to treatment is a bit delayed. And I don't think this patient was so immune compromised to get a non-tuberculous mycobacteria. Nevertheless, it can still be a possibility. Fungal infections is always a possibility. Aspergillosis or mucor is always a possibility, but they don't typically involve the lymph nodes. In fact, their involvement of lymph node is lesser than nocardia involving the lymph nodes. So again, I would put it less. Now you have some of the endemic fungal infections like histoplasmosis and blastomycosis and others, which I think is only here for the sake of differential diagnosis and discussion, but I don't think I would put them high up in the differential. So I would think that the syndrome which happened in December, the symptomatology and the signs possibly tells me that there must have been a disseminated infection, probably tuberculosis, maybe nocardiosis, and the others which I discussed are lower down. Now, what's the incidence of tuberculosis after transplant? This is a large data from the Spanish transplant registry in bone marrow transplant group, and the incidence is 0.2%. And I'm not surprised. That's not an endemic disease in Southern Europe. So obviously you will not see so much of tuberculosis in Spain. Now there is some Indian data, at least in the allogenic transplant from the Rajiv Gandhi Cancer Institute, and there the incidence is around 4.9 to 5%, which again is probably corroborated in other groups also, that the incidence of TB post-transplant would be 5 to 8%. Nocardiosis is a very neglected diagnosis. It's a great masquerada. It can present in any ways, and in immune compromised patients, it is a possibility. I keep it second in my list because the lymph nodes usually are not involved. And the most important is that this patient was on Septran, and usually the Septran will protect. Now, among the species of nocardium, the drugs are not too many, and sulfonamides is one of the drugs, and that is why I say that possibly it is not nocardiosis. Now we come to the terminal event. So day 140, the patient came with sudden onset of dyspnea. The X-ray showed a right upper lobe mass with bilateral infiltrates. A CT scan done on the 24th February now showed a lung mass in the right upper lobe region with bilateral infiltrates. A transbronchial biopsy was done and an FNA. The cardiac cause of respiratory distress was ruled out. The echo was normal. The pro-BNP was normal. The deep venous thrombosis screen was normal. The pro-cal was normal. Now, the ABG showed respiratory and metabolic acidosis. Unfortunately, the patient developed asystole and he could not be revived. Now, when you look at the CT scan of the day 141, you can see lymph nodes in the supraclavicular region, and you can see this mass in the right upper lobe of the lung, and plenty of nodules on both sides. Now, when I look at this mass, it looks that it just continues to the residual lesion which was there even after the upfront chemotherapy given before transplant. So I would be tempted to suggest that this is probably the disease coming back because it seems contiguous from whatever the pathology was there before transplant. And when I look at these nodules, I feel that probably it was the hematogenous spread of the lymphoma, or it could be mixed that there is some infection and there is a mass up there. So in my opinion, the worsening which was fatal, I would think that at this point of time, the disease had progressed. And why I say that the disease was progressed is because even if you do a transplant for lymphoma in the first partial remission, there's a high chance of recurrence. And usually the recurrence happen in the first 6 months to a year. So probably this is an aggressive lymphoma, possibly DLBCL, which has now recurred in the last scan in February. The odd is the hematogenous spread of nodules, which again can happen. Now, can this be the worsening of the infection which I alluded to in December, where I kept tuberculosis as the first and nocardia as the second? Probably not, because it did improve significantly until unless it's a multi-drug resistant pathology. If at all the December pathology was an infection, I don't think it would have progressed to cause a respiratory failure and death. Was it a new infection? I don't know. But there doesn't seem to be any setting for the patient to have bacterial sepsis. So what's my final impression? The basic diagnosis, I believe, is a high-grade B-cell lymphoma. The Hodgkin and others is less likely. The early pulmonary complication, I'm not sure, but I would keep drug-induced lung injury higher up. The reason is because of the fibrosis seen after a month, but it can also be engraftment syndrome, which is there. The December pathology, the symptomatology, not pathology, symptomatology was probably a disseminated infection, where I would keep tuberculosis as first, and maybe nocardia or any of the atypical organisms second. I don't think I would keep the recurrence of the original disease in the December symptomatology. The terminal event, in my opinion, would probably be a mix of both the disease progression and whatever that infection was in December, though anything is possible. I would end by saying that in CPCs, clinicians are always the losers. If your diagnosis is correct, then people will say that it has been rigged and you knew the diagnosis. If the diagnosis is incorrect, then everyone would say that you're not a good clinician, which probably I'm not a good clinician. So I would hand over to the genius so that so that Dr. Kaur can shed some light to the actual diagnosis. Thank you for your attention.
Excellent discussion. I think all the points were touched and every symptomatology was discussed and reason was given for that. Now I invite any comments, any alternate diagnosis, or any questions for Dr. Navin from the audience. People who don't know the diagnosis as yet would like to offer some diagnosis. Everyone agrees with you, I think.
You have to agree with me. That's most important.
That we'll see. I think the radiologists will come in the picture before us. So, if there are no comments, I'll call the radiologists. I think they see the whole picture much before us always. And I call Dr. Kritika.
Thank you. Thank you, Dr. Kavneet, and thank you, sir, for that wonderful discussion. So I'm just going to, we had a few cases. Yeah, but I think sir had a different set of cases.
Okay.
I think we had a slightly different set of images. So I just emailed some to myself right now.
Just share the screen.
Is my screen visible, sir, to you on your side as well?
Yes, yes.
Okay, so we have 3 CT scans over here. This is the one from November, this is the one from December, and this is the terminal event. So when we look at the November scan, these are the axial lung window images, where, as you had mentioned, there's significant fibrosis, and the predominant finding is one of fibrosis. So there is this is an organizing pneumonia pattern on the CT. So our thought also at this time was that this looks like a drug-induced entity. It looks like perhaps a drug-induced organizing pneumonia at this point. When we look at the December scan, we have an axial CT scan lung window again from December over here. And we see that the changes that we saw in November have significantly resolved in December. We don't see, or we see very little fibrosis, which is predominantly in the periphery. So there is certainly a response to whatever therapy has been given in the interim time. And in addition, though, this is the time when the patient had a lot of hypoxia. So what we also do see is a lot of ground glass, which we thought could be infective. And we would have thought of perhaps a viral pneumonia as the etiology at this point. And moving on to the February scan at this point in time, we have one mediastinal window. This is the mediastinal window, where we see an extensive, a large mass, which is non-necrotic. And this looks like a lymphoma recurrence at this point in time. Very typical large non-necrotic mass involving the mediastinum. And when we look at the lung window images of this time, we see several nodules. These were present in all lobes, did not have a central peripheral or craniocaudal predominance. And at this point, none of the nodules showed any cavitation either. So our differential at this point was also primarily one of relapse, and we did keep a possibility of superadded infection as well. But the lung findings to us also looks like recurrence. We would think of a relapse of a lung involvement by lymphoma itself as the first possibility. So, thank you.
Now I call Dr. Sneha from Nuclear Medicine to discuss the PET findings.
Good evening, everyone. So I'll be discussing the two PET scans. The first one was done in December 2021, and the second one was done in January 2022. So here you can see the maximum intensity projection image for the December 2021 scan. We could actually see cerebellar lesion. You can see the supraclavicular bilateral supraclavicular nodes that are metabolically active. You can see metabolically active mediastinal lymph nodes. You can also see uptake in bilateral lung fields with metabolically active right lung nodule. There were also a few abdominal lymph nodes that were metabolically active as well. So here there's the axial fuse PET-CT view for the December 2021 scan, where you can see a metabolically active cerebellar lesion. You can also, in the same scan, axial fuse PET-CT soft tissue window, you can see metabolically active bilateral supraclavicular lymph nodes. Here you can see the mediastinal lymph nodes that are also metabolically active. And in the lung window, you can see bilateral diffuse ground glass opacities along with fibroreticular changes that are showing increased metabolic activity. Now, after 1 month of therapy, there was another PET-CT done in January 2022, and you can see the MIP image for that scan. We could see a resolution in the cerebellar lesion that we will show in the axial fuse PET-CT image. You can also see a significant decrease in the size of the lymph nodes. Many lymph nodes had resolved, although there are some supraclavicular, left supraclavicular, some mediastinal lymph nodes that are still there. Most importantly and significantly, the bilateral lung uptake had significantly resolved in the second PET-CT. So here in the axial fuse PET-CT image, you can see the December 2021 scan and the January 2022 scan, and you can see that the cerebellar lesion has resolved. The size of the mediastinal lymph nodes seem to have been stable, although the lung lesions have resolved. The bilateral lung lesions seem to have resolved. Thank you.
In December scan, there was lung involvement, cerebral involvement, and this was the scan done actually after bone marrow transplantation. So in our differential, there was we have given that it could be because of the lymphoma either, or it could be because of the infection. So retrospectively going back, we have seen the follow-up scan that was done after 1 month. On that scan, as we can see, there is a resolution of the cerebral lesion. There is a resolution of the few of the mediastinal and supraclavicular lymph node, as well as the lung finding were not there in the follow-up scan. So some therapy has been given in between, and the patient must have responded to that, and that most probably we will discuss in the subsequent slides. We are supposed to hide this information from you.
Now comes the turn of the pathologist. So first we got a biopsy in 21, which this was a 22-year-old male and had a lot of mediastinal lymph nodes as well as supradiaphragmatic as well as infradiaphragmatic lymph nodes. And the biopsy was done from the mediastinal mass. What we got was a core biopsy. On low power itself, we can see some lymphoid aggregates, and then here we are seeing a lot of histiocytes. I mean, on low power itself, you can see it's not like a monomorphic lymphoma, which is like a non-Hodgkin lymphoma, but there's a polymorphous population of cells. Going on a little higher power, here we can see.
Dr. Kaur,
Kavneet, we can't see your slides.
can you share the screen? We
One
can't
second.
see.
Okay.
Yes.
Can you see the screen now?
Yes.
Oh, that's great. Okay, so the first biopsy was from the mediastinal mass, and as I was discussing on low power itself, we got 4 biopsies, and on low power we saw that there were some lymphoid aggregates, but the lymph node architecture was not maintained. We were not seeing the paracortical and the cortical zones. Then going on the high power, we saw that there was a polymorphous population of cells, including many histiocytes, a lot of eosinophils here, as you can see with the eosinophilic granules, some lymphocytes, and occasional plasma cells were there. And there were some sclerotic bands within the core biopsy itself, and there were foci of histiocytes. When you see a polymorphous background in a mediastinal mass, the first diagnosis which comes to mind is Hodgkin's. And after Hodgkin, because it seemed like this is an aggressive lymphoma, some other mediastinal gray zone lymphomas and T-cell lymphomas. Then we went ahead to search for RS cells, which are the typical Reed-Sternberg cells of Hodgkin lymphoma. In most of the areas, typical RS cells were not seen, but some mononuclear cells with conspicuous nucleoli were identified. And a lot of these cells were looking like, these are known as mummified cells, which have scant cytoplasm. And they are larger cells with hyperchromatic nuclei. So mummified cells and mononuclear RS-like cells were visible. And then there was one focus where we got like binucleate, a typical Reed-Sternberg owl's eye appearance of the cell. And then there were some of these cells with multilobation, which are the pleomorphic Hodgkin Reed-Sternberg cells. So because there was sclerosis present, there were typical RS cells, there were polymorphic RS cells and Hodgkin cells. Our first diagnosis was classic Hodgkin lymphoma. So we went ahead with the panel, and this is the CD3. So the background lymphocytes were predominantly CD3 and the larger cells were negative for CD3. Then this is CD20. Few of the lymphocytes and the lymphoid aggregates, they are positive for CD20. This is CD30, which was nicely and strongly membranous as well as Golgi zone positive, which is typical of Hodgkin lymphoma. This was PAX5. So PAX5, because CD320 are negative in most of these differentials, PAX5 is a B cell marker. And here we can see that the reactive B cells are very strongly positive for PAX5. However, the larger RS-like and Hodgkin cells are dim positive. They are showing dim positivity for PAX5. This is EBV LMP1. This is also showing granular positivity in the larger cells. So the diagnosis was quite clear on pathology. There were not much differentials as such. So the diagnosis was classic Hodgkin lymphoma. And the other lymphomas which come in the differentials are the T-cell lymphomas, which are PTCL, but you see a lot of the cells which are the lymphoma cells. They are the intermediate size cells with a lot of nuclear indentations and angulations. Then ALCL, you see hallmark cells and embryo-like cells, a lot of pleomorphism, which was not there. Then other lymphomas anyway are B cell, which were ruled out because of the EBV positivity. So the diagnosis was classic Hodgkin lymphoma, nodular sclerosis type. Then the bone marrow biopsy was done because it was an advanced Hodgkin lymphoma with mediastinal and bone involvement. However, the bone marrow biopsy showed around 40% cellularity. However, There was no involvement by Hodgkin. It was unremarkable. Then the patient was given ABVT. After that, still the patient had persistent lymph nodes. Then in July 21, excision biopsy of cervical lymph node was done. This lymph node showed large areas of necrosis. That must be some response to chemotherapy. But there were a lot of areas around the vessels, perivascular, which were still viable. And they showed a similar morphology. Here we can see nicely pleomorphic RS cell and in a polymorphous background with a lot of eosinophils and histiocytes. This is the typical RS Hodgkin cell. So this was again similar immunophenotype was seen. So the diagnosis was progressive disease, again nodular sclerosis, classic Hodgkin lymphoma. Then the patient was given salvage chemotherapy and patient underwent autologous hematopoietic stem cell transplant. After that, the patient, I think most of the PET and radiology we have discussed is at this point of time when the patient had a lot of lung disease with the ground glass opacities and a lot of, again the lymph nodes had reappeared and there was a cerebellar lesion. Because there were a lot of lymph nodes, significant lymphadenopathy was there. A PET CT was also done because clinically it was thought of as relapse. So this was the one which showed surprising findings. Actually, sir has almost hit the mark. We are seeing necrotizing granulomatous inflammation. So this will mimic tuberculosis on radiology. So here we can see the necrosis in the center and these histiocytes which are clipper-shaped or epithelioid at the periphery. And this necrosis has some bubbly sort of appearance, right? On low power only we can see that. So what are the granulomatous inflammation infections which come in this thing? We'll go for infectious causes only because it is a necrotizing inflammation. Necrotizing inflammation can be divided into suppurative and non-suppurative. Suppurative is when acute inflammatory cells are also identified within the granulomas. So suppurative infections are caused generally by fungal infections. And if you see neutrophils within the granulomas, that can be caused by mucor and blastomyces. And if you are seeing eosinophils surrounding the granulomas, then most likely Asper or Coccidiodis, I always pronounce it wrong, but we see it so rarely here, so it doesn't matter. Then the non-suppurative granulomas, the most common is mycobacteria, definitely in India, followed by non-tuberculous mycobacteria, that is atypical mycobacterial infections. Then the fungal infections which cause non-suppurative granulomas are histoplasma, which comes with infarct-like necrosis or sheets of foamy histiocytes. Then cryptococcus. Cryptococcus is the one which causes bubbly appearance within the histiocytes as well as within the necrosis. Then comes pneumocystis. Pneumocystis also causes non-suppurative granulomas. So when you lower the condenser in this thing in a necrotic field, what you can see is you could start identifying some organisms which are grayish pale color with a shiny capsule, refractile capsule you could see. Here also you can see in necrotic areas. So we went ahead to do the fungal stains. This is silver methenamine stain in which you can see the silver has deposited, that is black in color. And so you are seeing this is a fungal infection which has yeast-like morphology and it has narrow-based budding. Here you can see narrow-based budding means the budding and the daughter cell is attached to the mother cell with a narrow base. That is narrow-based budding. So it was silver methenamine positive. This is PASD, that is periodic acid shift with diastase resistance, with diastase. So you can see here that this organism is again positive. So these are yeasts which are fungal yeasts which are variable in size, and so you can see small to large size yeasts and they are showing narrow-based budding. So what are the yeast-like organisms which can cause granulomatous inflammation? First is histoplasma, but that is ruled out because they are generally very tiny and you don't see them on histopath as such. You have to do special stains to see them. Then comes the cryptococcus. Cryptococcus is the one which shows a lot of variation in size. They are round in shape and they show narrow-based budding. Then comes the blastomyces and coccidiomycosis. In this, These two are extremely rare in India. But the main differential which comes here is the blastomycosis, because they are also large yeast, they are round, but they show broad-based budding, and generally they are unencapsulated. So how do we show the capsule? Cryptococcus is capsulated and blastomyces is unencapsulated. So we do staining with mucicarmine and Alcian blue pus that stains the capsule, that has the polysaccharides within the wall. And also Cryptococcus has melanin, and that is one of the reasons why it's so virulent. And you can stain that with Fontana Mason. So here, blastomyces, I am just showing this for an example. Blastomyces is the one with broad-based budding. They are large yeast. Cryptococcus are similar size but variable size and narrow-based budding. Histoplasma are quite tiny compared to the two, and they come in clusters. Then coccidiomycosis, they generally have daughter spores within the spherule, so that is completely ruled out. But sometimes, as we saw in the recent COVID pandemic, a lot of mucor cases came, and that when you see only the spores and not the sporangia, and you don't see the hyphae, that can become confusing with yeast-like infections. So then we went ahead to do mucicarmine. Mucicarmine was strongly positive within the cell walls of the Cryptococcus, and Alcian blue was strongly positive. Then we polarized it under the microscope, and it showed nice, beautiful Maltese crosses, which have such a beautiful starry sky appearance. So the differentials were all the yeast-like organisms. So we did special stains, and we came to the conclusion that it is Cryptococcus. Other organisms which show Maltese cross are Cryptococcus, Histoplasma, but the Histoplasma Maltese crosses are extremely tiny. And then spores of mucor and aspergillus. This is from the spores of mucor and aspergillus. They also show Maltese cross, but they're generally pigmented. And then when you hunt, you will find some hyphal form or sporangia. So you can exclude them, yeast-like organisms, in the differential diagnosis. So the diagnosis at this point was Cryptococcus lymphadenitis. I mean disseminated Cryptococcus, because then the CSF antigen was done, which came out to be positive. However, CSF cytology did not reveal any Cryptococcus. Then the patient was treated and the patient responded. Then again the patient came with enlarged mediastinal mass and a lot of opacities within the lung, parenchyma. At that point, lung biopsy was done, and a biopsy from the mediastinal lymph node was also performed. The lung showed acute fibrinous organizing pneumonia. You can see that there is some thickening of the interstitial septae with the fibrosis, and there is inflammatory cell infiltrate. And on lobar itself, you can see some pale pinkish material within the alveoli. Here you can see some plugs which are organized, so it is known as organizing pneumonia. And here you can see fibrin and histiocytes within the alveoli. So it is acute organizing pneumonia, which has multiple causes, which can be drug-induced as well as certain infections can also cause. But we didn't pick up any infective cause in the biopsy. Then the clot core biopsy from the mediastinal lymph node was done. That showed relapse of classic Hodgkin lymphoma, because some RS typical Hodgkin cells were identified within the clot core biopsy. So the final diagnosis is classic Hodgkin lymphoma, nodular sclerosis, which progressed post ABVD. Then there was disseminated Cryptococcus post salvage therapy and autologous stem cell transplant. And post therapy of the fungal infection, there was relapse of classic Hodgkin lymphoma. So Cryptococcus is an encapsulated yeast, and there are the two most common species, which are Cryptococcus neoformans, which is more in the immunocompromised, and Cryptococcus gattii, which is more in the immunocompetent. And they preferentially occur in persons with impaired cell-mediated immunity. That is the most important thing to this thing. And so how does the body respond to Cryptococcus? It generates mostly the helper T cell response, and that is how the granulomas are. So when the cell-mediated immunity is down, that is when the Cryptococcus can spread and disseminate and cause infection. Otherwise, the body can control it with formation of granulomas, and with the Th1 response with the production of interferon gamma and interleukin 2. But so the thing is, protective mechanisms are Th1 response, but exacerbation of disease is seen when there is an anti-inflammatory Th2 response. So Th2 response is anti-inflammatory and it's more immunoglobulin mediated. It is important to see that here because what Hodgkin does is it suppresses the Th1 formation of Th1 helper cells and it promotes the Th2 helper phenotype. So when Th2 phenotype is there, it decreases the cell-mediated immunity. Then coming to nodal cryptococcus. This was cryptococcus which was identified within the lymph nodes. That is extremely rare. Only few case reports are there. Mostly they are associated with HIV. I only found 1 or 2 which were associated with Hodgkin or post-transplant, and that was also solid organ transplant and not hematogenous transplant. Then how does Hodgkin lymphoma contribute to the cell-mediated decrease in cell-mediated immunity? It is a B-cell lymphoma, but it is a lymphoma which is characterized by very few lymphoma cells. Most of it is the microenvironment. So the microenvironment is very important in Hodgkin lymphoma. There are so many of the T cells which are rosetting around the RS cells. Then, but they are all ineffectual to control the tumor cells. And also Hodgkin lymphoma patients are prone to infections even before the therapy starts, therapy is given. So onset of immune deficiency has been seen, which it precedes the diagnosis of Hodgkin, it worsens with the advanced disease and improves when remission is induced. So what happens is T cells, it causes skewing towards Th2 and Treg differentiation rather than Th1 helper phenotype. So that is what we saw, that is what is required for crypto. So crypto and Hodgkin can occur together because of that. So incidence of cryptococcal infection in Hodgkin lymphoma, it was very high in the beginning in 1950s, but once less steroids and alternative therapies came, it is now almost up to 2.7%, which is slightly higher than endemic. Then association is thought due to derangement of the T cell function, and risk is more when their patient had more than 12 months of disease, stage 4 disease and extensive pre-treatment. So this patient had received along with ABVD and other salvage chemotherapy. And this was a study in which there were 46 patients with cryptococcosis over 16 years, and the most common underlying disease was Hodgkin lymphoma. There was another study of Cryptococcus neoformans infections in malignancy, and among that, lymphoma was the most common and Hodgkin lymphoma was the most common among that, followed by T cell and then B cell lymphomas. Now coming to autologous hematopoietic stem cell transplant and Cryptococcus. So in this, the incidence is quite less because autologous hematopoietic stem cell transplant doesn't cause so much of immunosuppression. Although in solid organ transplant, it is much more because of high immunosuppression. Rarity in this thing is because during thymic regeneration of transplanted cells, there is proliferation of Th1 cells. So that prevents the fungal infection, specifically crypto. And widespread use of antifungal prophylaxis is also another reason where because the incidence is less. So what are the possible mechanisms for increased susceptibility? One is that delayed and incomplete recovery of cell-mediated immunity because of some complications, and also because of underlying lymphoma, which may still persist and cause dysfunction of the T-cell mediated immunity. Then, especially in post-transplant patients, it is very important to keep a high index of suspicion and do a biopsy or other microbiological studies so that it can be picked up early, because it can be life-threatening because it disseminates to the brain very easily. This is a study in which they showed that there were only 24 cases till now in this literature, which are Cryptococcus associated with hematopoietic stem cell transplant recipients, and all were associated, all the transplants were done in cases of lymphoma or leukemia, and Hodgkin was one amongst them. And in all of them, CNS involvement was there, fungemia was there, disseminated disease was there, but lymph node involvement has not been identified before in these patients. Then coming to CMV and Cryptococcus, that I'm just pointing, because in this patient CMV viremia was noted in the beginning and then only the fungal infection came. So it is shown that CMV reactivation, when it is seen, because the prospective monitoring is done after transplantation. If you see CMV viremia, that can precede the invasive fungal infection and therefore should be considered as a risk factor for a late fungal infection. This could be due to two reasons, because CMV also decreases the cell-mediated immunity, and also the antivirals, they cause neutropenia. Okay, so the take-home message is fungal infections post hematopoietic stem cell transplant are extremely rare. The nodal presentation of Cryptococcus infection is also extremely rare. Everything is extremely rare on this slide. Hodgkin and crypto association is known because Hodgkin decreases the cell-mediated immunity, and CMV viremia may precede fungal infection post-transplant. So I would like to acknowledge Dr. Soumya Ranjanmalik and Dr. Prashant Ramtake, who were the one who made the diagnosis. Then Dr. Anchal Thakur, she's in charge of CPC. And also Dr. Atul Sharma, Dr. Raja, and Dr. Sneh, the clinical colleagues who were very supportive. And I would like to end, if there is cell-mediated immunity in Cryptococcus, then you see these large Titan cells, or these are known as Crouton cells, which are which look like Teuton cells, but they have Cryptococcus. So these are the Crouton cells, which we didn't see in our case because of low cell-mediated immunity. Thank you. Now I would like to call the clinical this thing. Sir will just summarize the treatment.
Hi Navin, good evening. So you did an excellent job and probably you were very close. Probably I wouldn't have gone too far that way also. So
Sir, slide had Cryptococcus there in one of the slides.
Yes,
yeah,
one of the slides
sir,
had it, but
you
think
you were almost touching, yeah, almost at the same line. So we learned a lot of lesson from this particular case. This person, very bright student, probably he had a Hodgkin's lymphoma. It's supposed to be highly curable. Unfortunately, didn't go into remission. And we believe that this is one situation where even the partial response, probably autologous transplant may be useful. So that was the reason we went ahead with the transplant. Unfortunately, during the transplant course, he developed initially engraftment versus PCB and this thing. Thereafter, a couple of admission in and out of the hospital. Since he was working also, he was working from home, so he did not want to stay in the hospital. After the first discharge and when he was readmitted, we had noted that the CMV titers were high. So that was, and he was getting bicytopenia. So that was he was started on antiviral also. So this person, he developed all possible complications of transplant. He had bacterial infection, he had viral infection, and at the end he had the fungal infection also. But another important aspect of this particular case is that it's always better to do a biopsy whenever you get a chance, because these patients probably they may either if this Hodgkin's may have transformed to high-grade non-Hodgkin's lymphoma and so on. So that was the reason. But for the biopsy, we wouldn't have come to the diagnosis of the Cryptococcus. That is probably we did do the retroviral status check the retrovirals twice. This was negative, so it wasn't HIV related. That is for the sure. And another point was that probably he was starting on antifungal that showed this response based on the presumptive diagnosis of fungal infection, based on the because we thought the cerebral lesion will be unlikely in Hodgkin's, so we thought either this is fungal or the lung and this thing. So we started on. He had some reaction to M4B, so we started voriconazole and he did respond to that. We continued. Thereafter, once we came to know about the diagnosis of the Cryptococcus, we thought that let us switch to the M4B. But from the past previous episodes of the allergic reaction, he did not want, and since he was getting better, he insisted that let me be on this voriconazole. So in the end, we don't know whether what went wrong, but there was mixture of the two. Initially, we thought this is a disease. The biopsy showed this is some kind of an infection. In the end, we thought that this is worsening of infection. The biopsy did confirm that this is a disease. So that is the requirement that we should keep on doing biopsy whenever we get a chance. Questions or comment from the house or this thing? We are already late, but from pathology or so We have around 100 recently reviewed 130 or 40 transplant that include 170, 210 transplant, 134 this thing Hodgkins, 80, 90 non-Hodgkins. We didn't find any of this thing. We do end up using antifungal because they do not respond to antibiotic. That is a standard protocol. You give antibiotic, wait for 48 hours, doesn't respond, add another antibiotic or based on the clinical situation. So we have no proven fungal infection, and least the cryptococcus. Entire 3 decades at IRCH, I have seen 2 cases of the cryptococcus, that too in the setting of the HIV. And tuberculosis probably that would have, if you were to ask me this thing, lymphoma first, and second would have been the tuberculosis. So maybe that the neurology probably would like to show cryptococcus and this thing, or any usually. Do you see, how often do you see in non-HIV setting or this? But you don't need to see the kind of nodal presentation. So that was extremely uncommon for us. Naveen, I probably, without I said that this thing, biopsy, we wouldn't have come to a diagnosis.
I think what must have predisposed to cryptococcus is also, sir, the steroids, which was used for fairly long time. Just like the CMV viremia. And if antifungal prophylaxis was not given at that point of time, it may predispose a bit more. Too. And voriconazole is a good drug for cryptococcus. So that's why he responded to the voriconazole.
Any other comment or?
I'd like to thank again Dr. Navin for such an excellent discussion, and I must congratulate for almost hitting the bullseye. So yeah, so I think we'll conclude the CPC at this point.
Yes. Thank you, Naveen. Thank you
Thank you,
everyone
sir.
for attending.
Thank you very much.
Thank you everyone for